Okay, so why don't we get started? Good morning, everyone. Welcome back to the UofT Grand Rounds. It's our pleasure to have a collaboration with Sick Kids today and the triumphant return of Crystal Chun. So I'll hand it over to John to introduce her.
Good morning, everyone. So welcome back. One of our superstar residents, Crystal. Feels like you've just left, but you've actually been gone for quite some time, actually. So Crystal has been down to Boston, where she trained in pediatric ophthalmology at Harvard. And I believe you also spent a year as a practicing attending there before returning home. So I'm sure you have some very interesting tales to share with us. I will let you and your team begin. Thank you.
Great, thank you, Dr. Lloyd. And so this morning, I'm going to have our PGY2 Corral present a case that I saw as a fellow. And without further ado, take it away.
Good morning, everyone. It's a pleasure to be here and present this case. So my name is Kirill. I'm one of the PGY2 residents, and this is a case on a button battery-induced chemical injury in a child. So this is actually a very rare presentation in pediatric ophthalmology, but it's relatively common and serious when considered in the context of pediatric emergency medicine. So you're on call and you get a page from an outside emergency department.
Wait, Carol, go back for a second.
Sorry, yes.
Just want to remind everybody that we're going to try the QR codes again. So if you got your QR reader, you can quickly scan that, and that way you've got an instant access to the evaluation. So since everybody's glued to their phones, if you just quickly do your QR reader or your camera, even your iPhone camera on that QR code, you have the eval ready to go. Okay, carry on, thanks.
All right. So you're on call and you get a page from an outside emergency department. It's about a 2-year-old boy, previously healthy, no problems. Story is that he was playing with his older sister with a doll at around 9 p.m. last night. Supposedly, the hair of the doll hit the right eye, as per his mom. He was a bit grumpy, but no redness. He slept well overnight. And then in the morning, he wakes up. He's very irritable. There's a lot of conjunctival redness. There's purulent discharge. And so they went to the emergency department. You get sent this picture. You see some lower eyelid swelling. You see what looks like some foreign body in the inferior fornix there. And it's an overall angry, red-looking eye. So, okay, you accept to have this patient come down for evaluation. On examination with you, the child is very fussy. You cannot take a visual acuity. Pupils are reactive, cannot take an IOP. From what you can observe, the extraocular movements are full. And when you look at the eye, you see again this significant lower eyelid swelling. You see what looks like a black foreign body in the inferior fornix, and you see this yellow, brownish discharge. So what to do next? So because of very poor cooperation with the child, the decision was made to go to the OR and do the exam under anesthesia. So what you're looking at here is you see a swollen lower lid. Again, redness of the conjunctiva and this yellow brown discharge. Here's another view. You can start to see a little bit more of the foreign body in the inferior fornix. So you proceed to extracting the foreign body, and what do you see? You see this round metallic looking object, and it looks as if when you take it out, that it has flat, shiny metallic portion facing the tarsal conjunctiva and a more narrow portion facing the tarsal conjunctiva. And you see that it's made quite the impression in the lower eyelid there. So when you take it out, you see that it's a button battery. It's an Ag3 button battery. It's zinc oxide, zinc and manganese dioxide alkaline battery. It was retained for 16 hours in the inferior fornix. So this is one of the most common type of batteries. And you have just a little review of the battery structure. And in the A node, the top part, there's a zinc, and then there's the electrolyte solution, potassium hydroxide, which is a very strong base. So how do they cause tissue necrosis? There's multiple mechanisms. The first one is, of course, going to be related to the leakage of the alkaline solution here. The other part is going to be caused by a creation of current. As soon as the battery is placed into tissue, it will create a local circuit where electrons will flow from the A node to the cathode. And of course, there's going to be some pressure-induced necrosis. Now, the way to think about this is that because the A node, or the narrower part, contains the alkaline battery content which will leak, it will actually it will be the site of the most extensive damage. So one way to remember that is to think about the narrow side, its negative side, A node, cause necrosis, and because it's an alkaline solution, it will cause liquefactive necrosis. So injury can develop very quickly and can be very serious. As I mentioned previously, this button battery injuries are the most commonly studied in the context of pediatric emergency medicine in the context of esophageal injury. So typically, instead of getting stuck in the fornix, children eat them. When studies were done to try and determine what actually happens, so in vitro, you will get very rapid rise in pH to about 12.3 and a temperature rise to 44 degrees in less than 2 hours. In vivo, pH can go as high as 10.8, with injury being more severe in the alkaline side, and mucosal damage in the esophagus within 15 minutes and in the eye within 5 minutes. And in our case, the battery was in situ for 16 hours. So why does this happen? So alkaline injuries cause severe burns due to very rapid penetration into ocular tissue. They do this by two major mechanisms. So there's saponification of fatty acids in cell membranes, so it leads to cell lysis and rapid penetration of the substance into the tissue. There's hydrolysis of interfibrillar glucosaminoglycans and shrinking of collagen fibrils, and this makes tissue more susceptible to enzymatic degradation. And because of the severe tissue damage, there's also intense inflammation. So the question is, when we're faced with an injury in the inferior fornix with our button battery for 16 hours, what are we going to do? What's going to be the approach to fix it? So when we examine the current literature here, there's 3 cases that were published, 2 in children less than 4 years of age, and 1 in an 18-year-old. Battery was retained for shorter than in this case, the longest being 8 hours. In all of these cases, you can notice that there was no debridement. There were topical antibiotics and corticosteroids to try temper down the inflammation. And in 2 of those cases, there were daily glass rods placed into the fornix to try and prevent symblepharon formation. So symblepharon is simply the formation of adhesions between 2 opposing surfaces. However, in all of those cases, there was formation of symblepharon. And perhaps the largest band here is in the case where the retention for was the longest. So in our case, with the retention for 16 hours, there's quite a bit of concern as to how can we prevent symblepharon formation and development of possible restrictive strabismus. So the management priorities then are, first of all, we need to irrigate and neutralize the pH. We need to explore the extent of injury. We need to understand how deep it goes, especially given the prolonged contact time. We need to debride all of the necrotic tissue. We need to control inflammation to try and prevent symblepharon formation, and we need to promote healing. So when we explore On the top left, you see the bulbar conjunctiva and fornix, and you see this green and also yellow, brown necrosis. We see similar appearance on the fornix and tarsal conjunctiva. And as you keep going, this green part is just a scleral lens to protect it here. And as you keep going, you continue to see this green discoloration and yellow sort of brownish tissue necrosis. When you put a litmus strip down into the inferior fornix, you see that it's very basic. Its pH is 9. So this is a video of an exploration. You do an irrigation, and irrigation was done throughout the entire case. So there's deeper injuries that you can see there. It's kind of difficult to obtain one single plane of dissection. You can see that the exposed tenons. This is the tarsal conjunctiva there. Okay. So there's no obvious plane of dissection due to the extent and complexity of injury. So the dissection is actually relatively complicated because of that. But debridement of all necrotic tissue is very, very important because we needed to ensure that as much of the potassium hydroxide was removed. So once we dissect down to the inferior rectus, we see that actually, thankfully, the inferior rectus is not necrotic and the insertion site is not significantly damaged. So this would be the inferior rectus here. So if we're then able to prevent symblepharon formation, we're probably going to be able to preserve normal extraocular motility and preserve the development, prevent the development of restrictive strabismus. So just some summary pictures as to what happened in the tarsal conjunctiva. So this is what it looked like before, with extensive necrotic tissue with greenish discoloration and yellow-brown discoloration of the tissue. Following irrigation and debridement, you can see that there was quite extensive injury, but now you're seeing mostly the absence of sort of this necrotic tissue. Similarly, on a necrotic bulbar conjunctiva, you're seeing dissection almost down to the tenons, and you can note just for all of these that leakage from the battery is sort of green or dark green. This necrotic tissue is brown, and thankfully here you can see a little bit of cornea. There's no limbal ischemia. So when it comes to sort of classifying alkali burns, the prognosis, the visual prognosis itself is pretty good. So back to our management priorities. So we've done irrigation, we neutralized the pH, we've explored the extent of injury, we debrided the necrotic tissue. The next step is to how do we actually prevent symblepharon formation? Our cases, the contact time was very long, the extent of injury is pretty extensive, and how do we promote healing? So one approach that is widely used is amniotic membrane transplantation for reconstruction of conjunctival fornices. This is a paper from 2003 from Sheffer Zhang, who actually now runs a company called Tissue Tech that sells amniotic membranes. This is a picture. This is a figure from his paper that shows basically reconstruction of the inferior fornix due to symblepharon formation here with the amniotic membrane. So how does amniotic membrane transplantation actually work to this? So it can promote healing and suppress inflammation. So the basement membrane of the amniotic membrane promotes epithelialization. The epithelium and stroma are actually sources of growth factors. So they contain many growth factors, so like epidermal growth factor, transforming growth factor, basic fibroblast growth factor that can create a microenvironment for cells to grow. the stromal matrix itself will inhibit cicatrization and subsequently symblepharon formation by decreasing TGF-beta signaling and fibroblast proliferation. And also the stromal matrix can help control inflammation by trapping inflammatory cells and inducing their apoptosis. And AMT can even be successful in severe cases with necrosis, such as seen in our case. This is an example from a recent paper. It's actually showing involvement of the cornea. And as you see here, transportation of the AMT can actually help with healing, even in cases of necrosis. However, despite these sort of case series and case reports, there should be some caution. When Cochrane Library did a review of amniotic membrane transplantation for acute ocular burns, they found that actually conclusive evidence supporting the treatment of acute surface burns with AMT is lacking. There's a lot of heterogeneity in the disease presentation. There's obviously variations in treatment. Everyone has their own preference for how do they do it, and there's probably a lot of bias in terms of how outcomes are measured, how long patients are followed up for, and so on. So while there's a lot of exciting sort of smaller case series and case reports, when the data is aggregated, there's a bit of a lack of conclusive evidence. So what was done in this case? So here's the amniotic membrane. The challenge was fitting this amniotic membrane into the fornices to make sure that it lies flush with both the tarsal conjunctiva, the fornix, and the bulbar conjunctiva, and to also kind of make sure that it stays in place. So the decision was made to proceed with a symblepharon ring made of IV tubing. Here goes into the inferior fornix. And then the amniotic membrane was trimmed at the lid margin. Post-op is a pretty standard cocktail of antibiotic drops, anti-inflammatory drops, ointment, and preservative-free artificial tears. First day post-op, actually, in the morning, the amniotic membrane was covering the ocular surface, but in the evening, it's became displaced downwards, and the superior conjunctiva showed a very mild injection. Patient was admitted overnight because the family lives far, and a general peds was consulted to rule out non-accidental trauma, and they did. About 1 week later, the patient returned. We were able to take a visual acuity at that time. Actually, the visual acuity was better in the right eye than the left eye. As you can see here, this is the amniotic membrane and a little bit of the IV tubing. At 3 weeks, the time was come to remove the symblepharon ring. So this is how the eyelid looks like. There's still, you maybe can see a little bit of a small lesion here in the inferior fornix. And when you look at the bulbar conjunctiva, you see quite extensive granulation tissue inferiorly, but thankfully without symblepharon. At this point, the pathology also came back from the case. So what you're looking at here is anything that's brown here and sort of amorphous is actually leakage of battery content. In the middle here, you're seeing a lot of liquefactive necrosis with basophilic debris. And you're seeing a lot of these nuclei. It's a very dense inflammatory infiltrate. So just describes the—
Here, may I ask a question?
Sure.
So is it true then, from what I understand of your talk, that the kid would have been much worse off if the battery's polarity had simply been reversed, like if it had been in the other way around?
It's possible because so the extent of injury would have then been the greatest in the tarsal conjunctiva. So it's possible that it would have I think you're probably a little bit safer in the sense that it's probably not going to, damage. You're not as much of a risk of damaging the eyeball as much as it is in the case the way it is now. But it's possible that the lower eyelid would have been significantly thinned and maybe even perforated. It's hard to say. But because the battery was, in our case, pointed the negative side was pointed towards the bulbar conjunctiva, I think there was a risk of erosion and maybe inferior rectus necrosis. That's why the debridement was done so extensively to try and rule that out. I don't know if that answers your question, but it's.
Sorry, I thought you said the brown stuff was on the tarsal conj and that was the leakage. So wouldn't that have gone on the globe if it was the other way around?
The tarsal conjunctiva, no, so the leak, so if we go back, you will see that the A node was pointing towards the bulbar conjunctiva. And the leakage was, yeah.
Correct. The bulbar conjunctiva was the side that had the anode, so that was the site of the more severe injury. And so we'll carry on. Thank you.
Sure. So, and we can go back also, show that a little bit more clearly. So at 2 months, these are the pictures of the child. It's kind of very difficult to see what, if there even was an injury. Again, a little bit poor cooperation, so can't do monocular visual acuity. Intraocular pressure is within the normal range, and when the child's in an attempted upgaze, there appears to be no restriction. So in summary, this is a very long exposure time of 16 hours of button battery, longer than anything else reported in literature. There was irrigation, debridement, and amniotic membrane transplantation, plus with symblepharon ring, and at least within the follow-up presented here, it prevented symblepharon formation. This is again a slightly different and more extensive approach than presented in other cases to date. So with this, I think it's also important to realize that the number of battery injuries is growing. This is in data from the CDC.
Carol, before you carry on, there was a couple of questions from the audience relevant to your talk. Can you see them there, Crystal?
Yes, I can. And I think I can answer the question about the use of suturing the AMT against the lid margin. And so this is something that we talked about in interop. The decision, retrospect, what we could have done was use TESEAL glue to try to seal it at the lid margin. We did not want to put the bolsters in place because he was a very active 2-year-old for which we're concerned that the bolster was going to be rubbed off and that it can potentially cause a corneal abrasion and causing a second problem. But in retrospect, TESEAL glue anchoring it at the lid margin may have helped. And then other thoughts along the lines of AMT was, I would love to hear from the audience later, is whether or not you think that a thicker AMT or like multi-layered AMT would have been beneficial for this case. And as for the other question that was on our chat was there any case reports of observed globe perforations? So to our knowledge, there has not been globe perforations, but good question, because in the GI literature, there has certainly been evidence of esophageal perforations and fistula formations.
That's right. Yes. So as you mentioned, exactly, there's cases of death have been reported in the GI literature from button battery ingestion and perforations of the esophagus. Yeah. So this is all happening in the context that the number of battery injuries is actually growing, and it's probably going to continue to grow the more the more prevalent electronic devices and battery-powered electronic devices become. And as you can see, these battery injuries are very common in children. You see here from this data that more than half of all injuries happen in children less than 4 years of age. And button type of injury, again, also accounts for more than half of all the injuries reported. So this is an important consideration to keep in mind if faced with this very rare presentation. So this I'd just like to thank you for your attention and time in allowing me to present this. And I think these are some acknowledgement that Dr. Chung has for her colleagues and collaborators on this case report. Thank you.
Crystal, I was just wondering if I could ask a question. When you were doing the dissection, was there any value in using a viscoelastic to lift the tissue up?
So I think what we were trying to do is that we were trying a variety of different things. We also tried to even inject under kind of subconscious injection just to see if we can lift. So we can, because the goal is to preserve as much healthy tissue as we could. We did not use viscoelastic. But we did inject some just normal saline subconch to assist with the dissection.
In Dr. Chen, there's a question from Dr. Angtong. Has Procera been used for less extensive conjunctival injuries? I'm not actually aware of data on that.
So I think that for the Procera, I think for our rationale for not using the Procera was because we were concerned about the fornix, because with the battery being there for so long, it was just bathing the entire inferior fornix, and there's necrosis all the way down in the fornixial space. And so we felt that this was the use of the IV tubing was something that they done a lot of children's for kiddies with Stephen Johnson's to try to preserve that fornixial space. So the initial thought interop was that we were hoping with the symblepharon ring that was going to stretch from the upper to the lower fornix, perhaps that will, even if the amniotic membrane kind of falls with gravity, that it will just fall with redundancy into the inferior fornix. That was sort of the thinking. To answer, looking at some of our chats here, to address the question about the Procera. So the Procera essentially is like an oversized contact lens that can be put on in cases of severe ocular surface damage. The Procera, one of the shortcomings of that is it's a large diameter, but it's not large enough to go from fornix to fornix, for example. And let's see here, scrolling along for some other questions. There was a comment that we can use amniotic membrane inlay in the areas of the conjunctival defect and over the amniotic overlay. So let me see here. I am going to see if I can do this and unmute people. Let's see if I can do this part. I think I've unmuted Dr. Bunsick.
Carol, while she's doing that, can you go back to the slides of the injury?
Yeah. So this is how it looked like in the fornix. You can see that there's the flat part is towards the tarsal conjunctiva. Then as you take it out, you can still see the anode. So it almost leaked kind of into the inferior fornix. And then
so even though it's very brown on the tarsal side, the leakage was still coming from the, obviously the anode side, just going down in and around.
It sounds like that was probably what's happening. Yeah.
Yeah,
because,
and go ahead.
No, go ahead, Dr.
I think I was just going to comment on the fact that when we took out the battery, it was eroded worse on the anode side than the cathode side. And so in these batteries, once they're eroded, then there's a potential of leakage of the battery contents. Particularly, most concerningly, would be the potassium hydroxide.
You see what I'm saying, though? In your picture here, the anode side was facing the,
So the plus side was the tarsal.
Was facing the. But actually, that's interesting, because I thought these batteries, the plus side was usually the bigger side.
No, the plus. So the plus side is the
I
bigger
got one
side.
here on my. I happen to have one here on my table, and it says plus on the bigger side.
Yeah. So this would be this side, right? plus.
Oh,
So
sorry,
the
yes. Okay, yes,
yeah.
yes. So, yeah.
Yeah, and as you can see, there's the narrower side kind of facing the bulbar conjunctiva. I do agree. It almost looks like the sort of the brown-green discoloration, the green or black discoloration is more or less towards the tarsal conjunctiva, though. So it's probably maybe leaked around. It's
leaked around and gone up or something.
Yeah.
And I think Dr. Bunsig raised his hand. Hopefully I've unmuted him.
Can you hear me, Crystal?
Yes.
Thanks.
Yes.
That's great. Very interesting case presentation. I think I may have missed something. In order to allow an earlier diagnosis, possibly, is there something that we might have, some information or thing we might have done earlier on to detect the problem?
Yeah, that's a great question, because we all kind of, the moment that this came out, we all sort of scratched our head wondering what it was, and how come the patient didn't have pain for so long. So so initially after the kid arrived, because he was uncooperative, we tried to arrange for an EUA, and an ED was assisting us with a sedated exam just to get some preliminary ideas. I think the concern was that because it appeared to be a metallic foreign body, and that the tissue just looked so necrotic and abnormal, we didn't know how deep it was gonna go. There were concerns that could there be some kind of glow perforation at some point? We don't even know what exactly this was. And so maybe if we would have removed the battery that was inside the ED, we may have started irrigation there while planning for the OR and transitioning. So that may have saved us an hour. But I think because there's a logistics aspect where they're coming from an outside emergency department that were referred in, had a drive-in. So even though it was direct to ophthalmology, that added to the delay. But he slept through the night. He was a kid who was fine the night before, woke up the next morning with a very red, angry eye.
And sorry, where did the battery come from, actually?
Yeah, so mom digged through all the toys. It seems like it was maybe a little wand from the sister. That was the best guess she had. She had no idea when this even came about. She looked through every single toy in the house, and that seems like the only one that was so-called missing a battery. So maybe when they're playing, who put it in, we don't know.
Okay, great. Thank you very much.
Yes, and I also have some other questions here. I also want to make sure we address from the chat group. Oral mucosal transplants. I am perhaps very curious on what our cornea colleagues would be using and what kind of success they've observed with regards to that. I'm just browsing through here. I see Stefan here. I think oral mucosal grafts have been used, but at the same time, I think that because amniotic membrane has been shown to promote, has an anti-inflammatory effect to promote epithelial healing. So for a fresher injury, that's something that's been advocated for and it's been tried for a lot of very extensive, for example, like ocular surface reconstruction in cancer patients with squamous cell. As for, let's see, Stefan has unmuted. Would you like to?
Yeah, no, great case. Like, I think also, like, my experience has been like in these acute cases, especially with chemical injuries like this, I think AMT is a great choice. I think the oral mucosa transplants, you know, we do this a lot in Stephen Johnson's, with a significant scarring. But I think in this case, the AMT was very appropriate, and I think you've got a great result.
Crystal, can I make a comment? It's awesome.
Yes, please.
Yeah, so just two quick comments. The tubing technique, the problem is it doesn't provide any force, and it can close, you can get closure around it. So there are cases from both the Boston group and others who've used it where the conjunctival and bulbar conj will close around the tubing, so you'll end up with a little sort of hole below that. That's the reason why we use the more solid, you know about the rings, you've written a paper on it. where you have the more solid rings that provide a greater area of separation. Second comment was about suturing to the lid. You can just suture to the anterior lid margin without using glue. And you can use like a 6-0 Vicryl just around the lash line. And that would actually secure the amnion a little bit better. And then the last comment was Yellen just published with Hall, Camera, and myself, long-term paper on the use of amniotic membrane in Stephen Johnson. It's just come on the BJO. And then we found that there are long-term consequences in these patients. So you had a great result, but you can get long-term both cicatrization and also keratinization of the conj. And probably in children, the biggest problem actually is, in addition to those problems, is things like entropion. So we had a very high rate of entropion formation in children compared to adults. So I think this child should be followed long-term, because there can still be complications because of the extent of the injury.
Thank you.
So Crystal, it's astonishing to me that this battery can get in there like that. Did you get any more history of how, like, does the child put it in themselves? Their sibling puts it in? Kirill showed a paper where some 18-year-old put it in their eye. What's an 18-year-old? They should know better. Was there any information why an 18-year-old got it in their eye? Like, you know, that's not a 2-year-old now.
Would you like to comment on the 18-year-old?
Yeah, I'm not sure how they got it into their eye.
It didn't say in the paper what happened. There was no history of how it got in there. No.
I can't recall at this point. I'm going to look.
And in your case, Crystal, did the sibling put it in there, you know, in the patient's eye?
Yeah, and so the answer is that was the running theory. What we think that may have kind of kept him from complaining of pain from so long might be that because the button battery sat so deep in the inferior fornix that it was away from the corneal nerves. So perhaps that's why he didn't wake up overnight complaining of pain, because it looked quite severe. So that was one theory.
Most of these batteries go up the nose.
They do, and there's been case reports of septal perforations. There's also been reports of any cavity, really, in the ear, in the vagina. Yeah. It's been published.
Yeah.
I think there's another question.
I realized there was one comment about the method of sizing the tubing. The tubing sizing was basically by we took an IV tubing and just tried to create a circumferential fit that will match the distance, the diameter of the upper to the lower fornix. So that's how it was sort of custom sized. But thank you for the input from our cornea colleagues. We're definitely, and from Dr. Ali and Dr. Anchong, to hear input to know if we have something like this where extensive tissue injury occur and the use of AMT interop. I do have a short case. Are there any other comments from our audience? Let's see. Let me see if I can unmute. Trying to. I think Dr. Bunsig wrote his hand. I'm trying to see if I can make this.
I think I've unmuted it. Have I?
Okay, perfect. Yeah.
Okay, Carol, this is a question for you. In your literature search, what happens to the kids who've swallowed it? Is it removed with esophagoscopy, or do they require esophageal surgery?
Yeah, so that's a good question. It really depends. So sometimes it can be passed. Other times, if it gets stuck, it can erode the esophageal wall, and there are, there's a spectrum of injury that can happen. You can get ulceration, but at the You know, the more dangerous spectrum, you can get there's a case report of an aortoesophageal fistula where the child ended up dying. And these injuries don't become obvious right away. It can happen, you know, up to a couple of weeks after the actual presentation and, you know, removal of the battery.
Thank you. Thank you.
All right. And let's see. All right, so what I'm gonna do is thank you so much for the presentation, and I'm going to see if I can drive this. Let's see if I can open our next short case for the remainder of the time. Let's see if I can do this right. Sorry for the delay. Now I'm going to share this screen and see if it works. Okay, let's see if that, is everyone seeing a different screen now? Yes, okay. So I thank you so much for all the great discussion and presentation. I'm now gonna present a short case for inpatient consultation that I saw. So we have a 20-year-old patient with MELAS or mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes complicated by multi-organ dysfunction. These included epilepsy, multiple strokes, cortical blindness. He is also TPN dependent, has intestinal pseudo-obstruction, JG2. He has pancreatitis, he has insulin-dependent diabetes, cardiomyopathy, respiratory failure, and end-stage renal disease for which he is dialysis dependent. And so he was admitted for altered level of consciousness and septic shock. He had a 1-month history of persistent discharge and redness in the left eye and was diagnosed with dry eyes and exposure keratopathy prior to admission, for which he was started on erythromycin ointment and Lacrolube. Now, ophthalmologist was consulted at day 3 of a history of left eye corneal clouding. His father reports that he pretty much closes his eyes throughout the day. And on examination vision, he blinks to light and intraocular pressure was normal. So for the left eye that we were consulted for, as you can see, there is diffuse conjunctival injection. In the cornea, there is diffuse corneal haze with the corneal opacity that's most prominent centrally. And there's also some thinning inferiorly. Now in the right eye, there's no conjunctival injection. The ocular surface is quite dry and the cornea is somewhat hazy. Of note, he does have significant blepharitis in each eye. And so with fluorescein, you can see that there is a total epithelial defect in the left eye. And in the right eye, the full doesn't quite show in the amount of details, but there's also some diffuse SPKs. So now the distribution of the epitheliopathy and infiltrate isn't quite consistent with exposure keratopathy. And we were concerned for potential left infectious corneal ulcer. A B scan was done, which was negative. Corneal scraping and cultures were sent. He was started on broad spectrum fortified and Vanco and ceftazidime Q1H. On the right eye, he was also started on preservative-free artificial tear every 2 hours. So the culture came back and it grew a moderate growth of Corynebacterium ambiculatum. And in fact, it was also sensitive to vancomycin. Similar to Staphylococcus, Corynebacterium is a part of the normal ocular flora. And a retrospective study that was done in India looking at 22 patients with microbial keratitis where Corynebacterium was a sole organism, the author identified that reduced immunity, either locally or systemically, is associated with Corynebacterium keratitis. This patient was followed daily, and by day 5, the sensitivity results have returned, and hence he was slowed down to topical vancomycin every 2 hours. But at 1 week follow-up, he still had really significant epithelial defects and was overall minimally improved. So at this point, what are our considerations for this persistent defect? Could it be vancomycin-related toxicity to the ocular surface? Could it be from, because he's so sick, he has multi-organ dysfunction and overall poor healing response? Might there be a secondary herpetic infection that's preventing from the healing? But what really bothered me about this case was the right eye of the patient was, he's on preservative-free artificial tears every 1 to 2 hours, and the ocular surface is just really, really, really dry. And the growth of the corneate bacterium on a corneal culture made me question the possibility of vitamin A deficiency. While we didn't see any Beto spots, there was these Beto spots results because of conjunctival epithelial metaplasia, mixed with keratin and corneate bacterium cirrhosis. But at the same time, this is a child who's on TPN. So how on earth do you become vitamin A deficient while you're on total parenteral nutrition? Let's briefly talk about normal vitamin A metabolism and transport. Vitamin A is typically stored in the liver. Pre-albumin and retinol binding protein, or RBP, they are synthesized by the liver, and these two proteins form a complex with vitamin A in the form of retinol in circulation, and they get transported to the neurosensory retina. Now, chronic TPN has been shown to be a risk factor for fatty liver and inflammation, which can lead to a reduced herpetic synthesis of these two transporters, which may in fact affect the transport of vitamin A to target tissues. In one series, they have shown that low plasma vitamin A level was detected in up to 43% on patients with chronic TPA. So back to our patient, he was chronically ill on septic shock. He also was found to have hepatomegaly with perihepatic fluid collection. He had elevated AST and ALT, and his vitamin A level came back to be less than 10, where the normal would have been around 20 to 80. This is a treatment schedule for vitamin A deficiency, and I've highlighted a portion for xerophthalmia and corneal lesions. So in our patients, on day 3 after vitamin A supplementation, the epithelial defect has much improved, and we were able to stop the vancomycin after 1 week because the epithelium has completely resolved. Afterwards, we've added topical Pred Forte to try to address the corneal scarring and neovascularization. As you can see, by 3 months, the corneal haze has overall improved in the periphery, still has that central scar. There's no recurrence of the epithelial defect. By 1 year, he was off the steroid by 9 months, and he still has some residual scar of the central axis, but overall much clearer compared to where he started. So briefly talking about vitamin A deficiency, in the developed countries, these often occur because of impaired absorption from our GI tract, disordered transport, poor intake. So in pediatrics, for example, children with autism, or they might just have reduced storage from liver disease or cystic fibrosis. By the time xerophthalmia is present, the patient is often very severely deficient from vitamin A. And a brief overview of our WHO grading of vitamin A deficiency. Light blindness is the earliest manifestation, and it usually responds to treatment in about 48 hours, but sometimes up to 4 weeks. Conjunctival cirrhosis happens because of epithelial metaplasia, and it resolves in 2 days to 2 weeks after treatment. Beto spot shown in the photo here has a foamy appearance, often appears in the temporal conjunctiva, while corneal cirrhosis presents as an edematous cornea and responds in 1 to 2 weeks after treatment. Carotid malacia and corneal ulceration occurs because there's an acute depletion of vitamin A storage in chronically deficient vitamin A patients. If there's superficial ulcers, they heal with mild scarring. Any bulgy area tends to flatten out in around 2 to 4 weeks, but depending on extent, there can be very significant corneal scarring as shown here. Xerophthalmic fundus is uncommon, and it presents as a late finding because of structural damage to the fundus in the form of these yellow-white deposits in the retinal periphery. Fluorescein angiogram reveals that these dots are focal retinal pigment epithelial defects, and they tend to have visual field abnormalities, and they respond to treatment in around 2 to 4 months. And so I would like to thank all my mentors and colleagues who were involved in this case. There was a lot of effort that people were putting their brains together and trying to help this child. And thank you so much for your attention. And I'm happy to take any questions or comments. Let's see.
Hi, Crystal. Thank you very much for those cases. They're both wonderful. I just wanted to ask, considering that these patients who are on TPN have such a high prevalence of vitamin A deficiency, what did they actually do anything to monitor it, or and how do they test, because you're kind of pumping this stuff obviously into them, so how do you know that they actually have low levels of vitamin A? How do you test it?
Yeah, so two great questions. So answering the first portion of do they routinely screen for these, the answer is, from what I understand, surprisingly, they don't routinely screen. There's not a routine schedule present for critically ill patients because the guidelines isn't so clear in the literature. Talking for all the nutritionists, actually what happened is after this particular case, actually, they now have a new protocol in place for patients who are on any kind of nutritional, any kind of TPN or even parenteral routes, that they do now routinely look at the vitamin A level. Now, that kind of leads into answering your second question, because vitamin A serum level isn't representative of the person's vitamin A storage, because vitamin A is stored in the liver. And there's been studies that tries to ask the question, well, can there be a surrogate marker that can be tried? One of the ones that are suggested is the use of the retinol binding protein, because it is because about 95% of vitamin A in circulation are bound to retinol binding protein. So that's been suggested as a surrogate, and in patients with vitamin A deficiency, in the AAO recommendation is that they would say, in addition to serum vitamin A, also look at that protein level and zinc levels.
Thank you.
Thank you. Oh, and Corral just can answer a previous question from Dr. Lloyd a little bit earlier.
Yeah. So about the question about the mechanism of injury in the 18-year-old that with a button battery stuck in the eye, it was actually a toy balloon with an LED, with a battery-powered LED that burst and propelled it into the eye.
All right. Well, thank you very much to both our presenters. Honestly, I think this is something that many of us didn't even know could even happen. And then on top of it, I had no idea that this little battery sitting beside my computer on my desk was a potential source of serious injury. I'm glad I don't have such a young child anymore. So many things to worry about. So Crystal, a couple of things. Can you just put up your last slide with the QR code for those who have joined late? We do send an email out for evaluations, but we are returning to my system, or our system, of the QR codes. So if you just take your phone, iPhone camera will scan the code, or a QR reader will bring up the evaluation sheet, so it's done. There it is. Thank you very much. And just a quick announcement for next week, we have our first virtual visiting professor of the year. We have Dr. John Chen from the Mayo Clinic, who will be presenting in neuro-ophthalmology. And once again, Crystal, welcome back to Toronto. We're delighted that you're here.
Thank you. Thank you very much. Thanks for joining, everybody.
Thank you, Crystal.
Thank you.
Thank you.